Hi, Hi everybody. I'm Yen Bui. I'm co-chair of the Professional Education Committee for ISTM, and it's my pleasure to welcome you to our first webinar for the season of 2021-2022. We have a distinguished panel of international speakers today, and it's my pleasure to introduce you to our moderator, Dr. Karen Litter, whom you all know. Dr. Litter is an infectious disease physician, head of infectious disease epidemiology at Monash University, Melbourne, Australia, and an immigrant health services, head of travel medicine and immigrant health services at the Royal Melbourne Hospital. She's involved in diverse areas of clinical and public health infectious disease research. She has had a lead role in Geo Sentinel, is a regional advisor for Journal of Travel Medicine, associate editor for Tropical Medicine and Travel Medicine and Infectious Disease, editor for Up to Date Travel Medicine section, among many other roles. Thank you, Karen, and over to you.
Thank you very much. And I'd also like to welcome everybody to today's ISTM educational webinar. I've got a couple of announcements before we get started. Please note that today's webinar is being recorded and that the audio and video of all attendees is muted. The way that webinar is going to work is that following my introductions, all three speakers will talk in turn, and then we'll have plenty of time for Q&A at the end of the session. But at any time throughout the speakers' presentations, please feel free to submit your questions through the Q&A at the bottom of your screen. Because you will be muted, the only way to submit your questions is through the Q&A. The chat function will not be monitored. We'll get through as many questions as we can after the three presentations. You might notice also at the bottom of this screen, there's a live transcript tab. It's labeled CC. This is the live caption button that is a free service provided by Zoom, which you can switch on if you like, although I'm told it's not 100% accurate. Also want to let you know that the slides for this program can be accessed on the handouts tab at learning.istm.org. You'll find that you'll find the webinar page on your dashboard once you're logged in. So welcome to the webinar entitled Dengue in the Time of COVID-19, the Experience in Endemic Countries. The webinar is brought to you by ISTM, the ISTM Professional Education Committee. Thank you, Sarah Cole and Yen Bui, and also Takeda Pharmaceuticals. And it's my pleasure to introduce the three tremendous speakers that we have. Firstly, Professor Annalise Wilder-Smith, who needs no introduction. We all know Annalise, a past president of ISTM, the editor of JTM. She's a professor in the Department of Infectious Diseases in the School of Medicine at the London Society of Hygiene and Tropical Medicine. She's a professor at the Lee Kong Chan School of Medicine in Singapore. She's a consultant to WHO. She has more publications and textbook chapters than I could possibly list. And Annalise will be talking about dengue and COVID, the impact of lockdowns. The second speaker will be Professor Aloisio Segurado. Aloisio is a professor of infectious diseases at the School of Medicine, the University of Sao Paulo in Brazil. And he'll be talking about dengue in the time of COVID experience in Latin America with a case study on Brazil. And then the third speaker will be Professor Pornthep Chanthavanich, who is from the Mahidol University in Thailand. He's the president of the Thai Society of Travel Medicine, immediate past president of the Asia Pacific Travel Health Society, Secretary General of the Asian Society for Pediatric Infectious Diseases, and treasurer of the International Society of Tropical Pediatrics. And he will be talking about overcoming dengue and COVID in Thailand. So now it's my pleasure to hand over to you, Annalise. Thank you.
Well, thank you again, Gui and Sahakol, for organizing, and it's a great pleasure to have Karen Leder chairing this session. So I assume you can all see my slides. Wonderful. So as we all know, the year 2020 saw an unprecedented scale and scope, and unfortunately also an unprecedented duration of public health and social measures, often just known in colloquial terms as lockdown, but it's really a range of more than 100 non-pharmaceutical interventions that countries in various combinations and various intensity have implemented in their countries. And there is actually a stringency index that you can download from the Oxford University website that actually follows up all these measures, as said, more than 100 that every country has done at different time points. So you can actually measure stringency index for every country. Now, the lockdown had an impact, obviously, far beyond COVID. I mean, it is, the lockdowns is the colloquial term. So actually, it's the whole range of non-pharmaceutical interventions have had a major positive impact on bringing down COVID, but also brought down various other infectious diseases. Influenza was close to zero immediately in China in the winter 2020. But then also in the northern and southern hemisphere, measles incidence also dropped despite a drop in vaccination rates, in fact, due to the interruption of routine immunization programs. And obviously these measles vaccination programs need to return to their normality, but measles also decreased. Also diseases due to other respiratory infections, sexually transmitted diseases, foodborne diseases, saw a more than 50% reduction in the report from Switzerland. And obviously, I mean, clearly there was a decline in all the travel associated imported cases. And here on the left, you see some of those publications, many of which were in a journal of travel medicine. So I'm now going to focus on the impact of lockdown with a whole range of non-pharmaceutical interventions on preventing dengue. And I'm really drawing from two pieces that we wrote. One is a perspective piece on preventing dengue during the COVID epidemic, and one is the impact of lockdowns on dengue, where we looked at various countries. So the repercussions of the pandemic response for vector control was obviously that vector control personnel and other resources, financial resources, were diverted to the pandemic response. Vector control personnel were not able to visit homes, or even because of mobility restrictions or stay-at-home orders, and all the fear factors. And to be honest, at that time, I personally thought, wow, dengue will now just explode. This whole lockdown experience, which was particularly strong in 2020, less so in 2021, thankfully, because of increasing vaccination coverage, really is now a unique natural experiment of social distancing and stay-at-home policies that may also help us understand how to better control dengue, or at least how better to understand dengue transmission dynamics. Now, we know that the timing, the duration, the stringency of lockdowns vary between countries, but maybe because of this so-called natural experiments, the wave of lockdowns may help unravel the following questions. Do reduced human-to-human contacts affect dengue virus transmission? What about the impact of reduced human mobility and international travel? But in the background, of course, is that there are lots of confounding factors, including that disease control and surveillance may have worsened during lockdown. So just to explain again the relative role, give you some background. There's a lot of discussion in the dengue community whether most of transmission occurs within homes or outside homes. Remember that Aedes are within home dwelling vector species with a relatively limited flight range. And often dengue occurs in local clusters. On the other hand, though, within household transmission events have rarely led to really high household attack rates. And that is because, households have family members of various age groups. And we know that the highest attack rates in the younger age groups, and then the older persons in endemic countries are protected. And then it's also unknown, whether most of transmission actually occurs outside of homes, for example, for children at schools, or for adults at work, or on the way to work, given that Aedes are day-biting mosquitoes, and most people are not at home during the daytime. And so interestingly, dengue transmission will differ in endemic populations that mainly stay at home versus those who actually spend most of their day at work or in school. Then there's another observation that we know from the past, and that's what we call the region-wide synchrony and traveling waves of dengue across countries. And this map just shows how the waves go within Southeast Asian countries and how travel is interlinked with the spread and the introduction of virus serotypes. And so you often find a synchrony that is just slightly, just like a little wave of the same serotype that then spreads in different countries. But there's another phenomenon which I need to explain to you, and which makes it so difficult to untangle, the factors and the risk mapping for dengue. So we all know with a natural infection of one serotype, you have robust, lifelong, solid immunity to that serotype. But with that initial serotype infection, you also have cross-reactive antibodies against the other serotypes that initially also cross-protect. And this cross-protection against the other serotypes lasts for about 6 to 12 months, after which it then declines. And as you know, after that, there is a risk of more severe disease. This is very important for the individual, but many people forget that it's also important for the population. If you had a major outbreak in 1 year, you would expect a much smaller outbreak the next year because of this cross-protection. And therefore, predicting and risk mapping and projections is very complicated because of this interference of 4 serotypes. Much more difficult compared to malaria or chikungunya or other diseases. So during this so-called lockdown, there are factors which could probably contribute to increased transmission intensity. So vector control programs halted, surveillance standards declined, prolonged stay at home with paradomestic transmission of dengue could have increased in-house transmission. There was increased contact time at home. On the other hand, you could also say, well, actually, we expect dengue to decrease because travel volumes between countries have dropped, between household movements has reduced, there's an overall underreporting because of disrupted surveillance, and maybe also because people who have dengue with minor symptoms may be less likely to go and seek out healthcare system just out of fear of COVID. So a question to you, what do you think? Did dengue increase in intensity or did it decrease? So really, the natural experiment can give us a lot of insights, and it's very important to assemble data on the disruption of vector control and to do entomological surveys and see, what was the impact of interrupted vector control. But also when lockdowns cease, to see, when you reintroduce all the vector control tools, what is the most impactful? And then also we can study human contact patterns to really tease out the relative role of within versus outside of home transmission, assuming, during the lockdown, that most transmission would have occurred at home. And really also look at human mobility. So these are the empiric data that we got, and we published it in this paper. So Singapore, Pakistan, Peru, Thailand, Ecuador, and some of the power countries initially reported an increased transmission intensity in 2020. Various countries like Taiwan, Bhutan, Sri Lanka, Nepal actually reported a decrease. Now, there are lots of methodological difficulties. Stringency and duration of lockdowns varied. The timing, the onset, there was a lot of lag time. Then very important, and that's why I showed you this slide before. If you had a preceding dengue outbreak, you may be protected next year. It may not have anything to do with the lockdown. Then temperature, seasonality is so different from countries. And that's why I think we have these heterogeneous reports that some countries showed a higher intensity and some a lower dengue transmission intensity. So we at the London School, we set out to study a study, and we did a multi-continent assessment of the impact of public health and social measures on dengue incidence. And the question was really to assess the impact with the goal of quantifying the strength and magnitude of association between the disruptions and dengue transmission dynamics. So we collected, this is still unpublished data, I'm sharing it with you, so we collected data from 23 countries in Asia and Latin America, and based on what we've seen in the past, we tried to project what we expect the dengue intensity to be in 2020, and then compared to the observed cases. We also documented climate data, population mobility, stringency of public health and social measures. And then, because there's a lot of collinearity between various factors, we did various statistical analyses to really look at it from different angles. So here you see the results. So in A, you see the relative change ratio of dengue in 23 countries. If it's blue, so the bluer it is, the more it has declined. If it's red, the dengue incidence has decreased. And here it's a relative change ratio, means compared to the expected cases versus the observed cases in A. In B shows the distribution of dengue incidence and the decrease both in Latin America and the Southeast Asia region. And the decrease, as you see, is more substantial for Latin America. So overall, a clear decrease in cases globally, except for a few countries like Singapore, Brazil, and some countries. C, so here the majority of countries saw, as we said, a decrease in 2020. And here we compare it to the 2014 to 2019 mean average incidence in those countries. And again, blue means you had a decrease, but you also see in red, some countries saw a decrease. D shows the change of government stringency. So the number of all those more than 100 non-pharmaceutical interventions that took place in 2020. And the black line here represents the beginning of consistent dengue incidence as it declined in 2020 compared to the monthly mean of 2014 to 2019. So the key findings here was declines in dengue incidence coincide with the beginning of public health measures. It was really most marked and very obvious from April 2020 onwards. And as you remember, that was about to start when most countries outside of China started in January, but of most countries to do public health and social measures. Except for Singapore, Ecuador, Brazil, and Peru, all countries experienced large declines in April. A decline about 60% in Latin America and close to 50% in South Asia. So even if you adjust for various other environmental factors, climate factors, really what was really strongly associated was the public health measures and the human mobility metrics. This table shows various variables as a result of public health measures and mobility behaviors, from staying at home requirements, stopping transport, to international travel controls, canceling public events, school closures, etc. The dendrogram on the left represents the degree of similarity. Some are, just collinear factors, and we had to tease out the collinearity. The table on the right is the strength of evidence of association between the public health measures in reduction in dengue incidence. And as you can see here, school closing had a major impact, as well as reduction in certain mobility factors. So the strength of association was really strong with school closures and non-residential mobility, which really means that the indirect evidence that this provides is that a lot of transmission actually does occur in schools. And this is consistent with other reports, including my own research that we did in Thailand. Schools are hotspots for dengue. Now, of course, it is not known whether the estimated 0.73 million cases of dengue that we saw a decline of are truly averted or just delayed until later years as pre-COVID-19 human movement behaviors will normalize. In fact, some are worried about that it may come with a vengeance, and it can become much worse. And we have the same, as you know, the same fears and concerns about influenza. So what needs to be done now to avoid collateral damage of lockdowns on dengue is really, we cannot lax with our vector control practices. And that means vector control personnel should receive early vaccination. They should be offered PPE in case they have to go into homes or are exposed, to a lot of people. During stay-at-home orders, it's very important to continue teaching the community to participate and engage in mosquito control activities, including targeted indoor residual spraying, making sure that your water containers are closed and that waters are emptied, that water storage have an appropriate coverage, that tanks and man-made containers do not collect rainwater, and all the education that we do should continue to be done. However, what we can do is maybe with this public health messaging, with the teaching and awareness of the public and the communities to really use both COVID-19 and dengue, and to address both diseases. Although the route of transmission is totally different, there are some parallels. So lastly, what are the implications for travelers? So overall finding, as we said, suggests that dengue decreased during the lockdowns in 2020. The strongest factor was school closures and limited human mobility. We want both schools to reopen and we want to restart human mobility. Now, as we do this, the fear is that dengue is likely to resurge, and the concern is it may even reach higher levels than before because of the diminished herd immunity. I remember the slide I showed you before. If you may be cross-protected for a year or two, but now the herd immunity may be decreased because of decreased dengue intensity. And when a new serotype comes in, we may have explosive dengue outbreaks again in 2022 or 2023. So travelers visiting dengue endemic areas in 2021 and 2022, as we now are seeing a relaxation of our travel restrictions, need to be aware of dengue, need to take the usual personal protective measures. And unfortunately, dengue vaccines are currently still not available to international travelers. Thank you for your attention.
Aloisio, over to you.
Hello. Let me share my screen. Can you see my slides?
Yes, we can.
Okay, so first, thank you very much, Karen, for chairing this session. And I would like to extend my thanks to the organizers at ISTM for having invited me to take part in this panel. And my job here is to discuss the overlap between two important epidemics, dengue and COVID-19, in a Latin American perspective. As you all know, both diseases are widely distributed in the globe, and Latin America is hit importantly by both of them. Indeed, as you see in this slide, the Americas account for 40% of COVID-19 cases since the discovery of this new viral emerging disease, and also accounted for about half, 46% in fact, of COVID-related deaths. Brazil alone accounted for 24% of all COVID cases in the Americas and for 27% of COVID-19 related deaths. The same picture, as you know, is however not true for dengue, since the Americas are less affected than other regions in the globe. Nevertheless, it is important to highlight that Brazil accounted for 56% of dengue-related deaths in the American continent in the last 2 years, 2020 and 2021. The overall epidemiological profile of the dengue epidemics in the Americas show that we had important outbreaks in years 2015 and 2016, with a significant decline in the following years of 2017 and 18. However, as Annelise has showed us previously, this is a natural wave of dengue epidemics, and we saw a resurgence of dengue epidemics in the Americas in the years 2019 and 2020, with a later decline in 2021. There is also an important heterogeneity in the distribution of dengue within the American continent, with prominence of the so-called Southern Cone, where Brazil is located, followed by Central America and Mexico, and the Andean region. In terms of mortality, you can also see that the important figures seen in 2017 were getting progressively reduced in the following years of 2018, 19, with a peak in 2020 and a later decline in 2021. Let's now have a closer look at the situation in Brazil. Important outbreaks occurred in the country in years 2015 and 2016. They showed that typical seasonality pattern with peaks in our rainy season in the early months of the year, which corresponds to our summer season. We then saw a sharp decline in the number of cases in the following years of 2017 and 2018, to again see an increase in the number of cases in 2019, reaching back to the peaks we saw in 2015 and 2016 of about 100,000 cases being notified every epidemiological week in the main season of dengue transmission. As you all know, SARS-CoV-2 was introduced in South America and particularly in Brazil in early February 2020. And since then, as you see in the graph below, a sharp decline in the number of dengue cases was reported. In fact, this decline is corresponded to about a 50% decline in the number of cases. An important question to be raised is then, to what extent did the dengue and the COVID-19 epidemics interfere with one another? part of my job has been made easier by Annelie's excellent presentation when she showed a number of factors that may interfere, leading to either an increase or decrease in the number of dengue cases during the COVID-19 epidemic. Let's start by talking a little bit about the studies our university has conducted in terms of the effect of restricted mobility in urban spaces, which were expected to reduce the number of dengue cases. I would like to share with you this interesting study published by Conceição et al., our colleagues at the University of São Paulo, which was based on Google Mobility database extracted from cell phones of the population living in the state of São Paulo. The measure here, the outcome, was the number of dengue cases according to the daily percentage of time spent at home. And important controls were used in the analysis, including seasonality factors and also paying attention to the time lag between isolation measures and disease onset to account for the intrinsic and extrinsic incubation periods. As you see in the graph, we can see in pink the intensity of staying at home following the sanitary measures for prevention of COVID-19 that were imposed by the local state government, and in blue, the number of dengue cases reported in the same time period. As you see, there is a very clear correlation that shows a decrease in the number of dengue cases being reported as long as isolation increased in intensity. In fact, after controlling for possible confounders, as I mentioned, days of the week, seasonality, and also the 20-day lag time, we could see a 9% reduction in the relative risk of occurrence of dengue due to the lockdown measures that were not only, as previously mentioned, home quarantine measures, but had to do with the closing of schools, of public spaces, theaters, cinemas, shopping malls, etc. Other factors may have contributed to this reported reduction in the number of dengue cases in Brazil and in other countries of Latin America. And I would like to raise your attention to the fact that diagnostic confirmation might have been compromised due to the work that public health officers had to do to deal with in the response to COVID, with discontinuation of surveillance programs, diagnostic infrastructure overload, and even the fear of the population to search for care after exhibiting symptoms that could be related to acute dengue. This is a graph that was shown in a paper published by our colleagues based on Pan American Health Organization data, showing that we had a sharp decrease in the diagnostic confirmation of dengue during the COVID pandemic. As you probably know, public health laboratories were fully committed to providing molecular biology testing for COVID-19 and could not be in charge of the usual demand for diagnostics of other infectious diseases, including dengue. However, we should remember that whenever we talk about a new emerging infection, we should clearly admit that knowledge is being built along the outbreak, with progressively more sophisticated studies being conducted, which may handle potential multiple confounders and reach a more solid evidence for a specific research question. The same happened with COVID-19, of course. In particular, the knowledge we accumulated regarding the clinical course of the disease. We now know that COVID-19 comprises 3 sequential phases: an early infection phase, where we have mild constitutional symptoms and fever, followed by the pulmonary stage in a number of patients, in a lower percentage of patients, which has to do with the pulmonary involvement and the need for hospitalization. And finally, the severe COVID-19 phase that reaches the top of the iceberg in the number of cases, that has to do with the hyperinflammation that comes up with the progression of the disease and leads to the respiratory distress syndrome, shock, and eventually death, COVID-19 related death. What can we say about risk factors for development of these severe COVID-19 cases? As we all know, older age was one of the first risk factors to be demonstrated as predictor of progression to severe COVID-19. After the outbreak continued, a number of other comorbidities were shown to play a role in increasing the risk of severe COVID-19, development of severe COVID-19, including cardiovascular disease, renal disease, previous pulmonary disease, cancer, and obesity. But what about dengue? I would like to share with you now an interesting study that came out recently in CID that was published by Nicolette and et al. And was conducted by our colleagues at the School of Public Health and the Institute of Biomedical Sciences at the University of Sao Paulo. This was a population-based cohort study in a remote location in the state of Acre, in the Amazon region. The location, this community is called Mancio Lima. It's located on the Juruá River Valley, very close to the Brazilian-Peruvian border. The first case of COVID-19 in that particular area was diagnosed in late April 2020. And from April to February 2021, about 1,800 confirmed COVID cases were reported in that region. Our colleagues at the School of Public Health have been following a population cohort in this area, doing studies on malaria and other infectious diseases. And so they took the opportunity of screening sera from these individuals for anti-SARS-CoV-2 antibodies and anti-Dengue antibodies using ELISAs provided by Eurimmune. We had a study population of about 1,300 people, in which 38% were shown to have dengue IgG antibodies in 2019, in the first occasion when blood was drawn from the people in their households. There was also a demonstration of 10.4 seroconversions for dengue along the follow-up for each 100 person years of follow-up. And in 2020, we ended up in this second blood collection with a 35.2% of seropositivity for SARS-CoV-2, out of which about 68% of patients reported symptomatic COVID-19. What were the predictors of symptomatic COVID in this population? Using a mixed effect logistic regression models, which were adjusted for individual and household confounders, as shown in this slide, we could show that age over 60 was an important risk factor for severe COVID. Of course, as previously hypothesized, crowding or having more than 9 people co-living in the same household had also an important impact in the development of severe COVID, of symptomatic COVID, I'm sorry. But what was surprising was to see that past dengue, evidenced by a seropositivity for dengue, was also shown a risk factor for the development of symptomatic COVID. What can we expect from now related to this interaction between dengue and COVID-19? I'm very happy to tell you that although mass COVID-19 vaccination started late in Brazil as compared to other countries due to an initially reluctant position of our federal government, which was in close opposition to public health officers in the states, despite having started mass vaccination late, we are very proud to show that more recently, this vaccination has progressed significantly. We now have a 50% coverage of the adult population, which has been fully immunized against COVID, and about 70% of the total adult population who has received the first dose of the vaccine. Consequently, we now are witnessing an important decline in the number of hospitalizations and deaths related to COVID-19. So this sounds very promising. However, the general context is unfortunately not favorable at all for public health. We were already experiencing an economic recession before we were hit by the COVID-19 pandemic. And Brazil was brought back to the poverty global map, which was very unfortunate after years of struggle to increase wealth of the population and reduce social inequalities. Economic recession has been increased with the COVID-19 pandemic, with a recent increase in the percentage of the social extracts which are in full poverty. Unemployment is peaking in our country right now with about a 14 to 50% rate of unemployment of the adult population, which of course brings back increased social inequalities, and with that, a natural trend of governors to be less committed with social policies. We are therefore very concerned that the following years will bring us difficulties for public health, and I completely share Annelise's point that we should be alert to make sure we come out of this fully committed with the continuation of public health measures related to infectious and non-communicable diseases. I would like finally to conclude that in Latin America and Brazil, these two important epidemics overlapped, that we have some evidence now that past dengue may increase the risk of developing symptomatic COVID-19, and that we have seen that there is a balance between interactions of COVID-19 preventive measures that can either reduce the incidence of dengue or increase dengue transmission, with different pictures being seen in different local contexts according to a number of intertwining factors that may concur for the final outcome. Finally, I would like to emphasize on the point that the post-COVID-19 economic crisis may really actually negatively impact living conditions of populations in middle and low income countries, and therefore can even further reduce investment in social and public health policies. There is an urgent need for a global and international coalition to prevent this from turning the worst. Thank you very much for your attention.
Can you see my slide?
Yes, perfect. Point them.
Okay, thank you very much. First of all, I would like to thank the organizing committee for inviting me to speak about the overcoming dengue and COVID in Thailand. I will cover dengue and COVID epidemiology in Thailand, the misdiagnosis, cross-reactivity, and the co-infection. Dengue is one of the major problems in many countries in the tropics. So it's our concern, and every segment must become involved in the prevention and control of dengue. In Thailand, dengue vector control during COVID is still going on. Even the lockdown, you can see these people are working with the mask on, but slightly is the reduction of the activities because of the lockdown. This is the incident of dengue by year, you know. So we know that dengue, like Professor Anneli said, the peak of incident will be every second or third years because of the cross immunity, cross protection. So you will see that the peak will be this one every third year. And we observe that if at the end of the year, you see in December and November, you see many cases at the end of the year and early next year, the case will be higher than the following years. Like this is 2020, in December you see, and January you see fewer cases. So we expect that in 2021, the case will be lower. And it's exactly the same. So this is our the dash line here is our expected case. This is the median case in 5 years. You see the expected case we expect to be lower than the median one. And you see during the COVID-19 2021, the case even lower than we expect. But the year 2020, like Professor Anneli said, in Thailand is higher. So it cannot say whether it's the lockdown process or it's the nature of the disease, but definitely in this year, the cases coming down. This is the distribution of the case between May and June. You can see in Thailand more prominent in this northern part of Thailand. This is Bangkok and metropolitan area, and northeastern, very few cases in the south. The COVID-19, we have 3 waves now. The first wave, very few cases. This is in the last year, in January to about in April. And the second wave in December last year. The third wave, which will be very high because we reached the peak in August, which is about 20,000 cases a day. But now it's declining. Today it's about 8,000 cases. So you see, if you compare to this figure of dengue I showed you before, that when the COVID increased, the incidence, the COVID coming down. sorry, dengue coming down. We in the country that dengue is one of our differentiation when we have fever. So this is the case that we have fever, skin rash with petechiae and low platelet. So this case was initially diagnosed as dengue, but no laboratory proof. And further, this case present with respiratory problem, and then COVID tests were confirmed by RT-PCR. So, do you think that this case is COVID co-infection with dengue? So you have to see that this is the rash. Okay, we haven't confirmed. This is the only clinical diagnosis. The rash in dengue, this is the rash in COVID in Thailand is about 15% of the cases. One of the that we see is urticaria, and this one necropapular rash with look like rash in dengue, and also this one necrosis. So if you compare to rash in dengue, we see also macropapular rash, but blanched when placed, and petechiae with when we do we see on the chest, but this one we do the tunicate test and we see over 20 petechiae in 1 square inch. So this is positive for tunicate test. And the other rash is conversion rash, which we see when the patient recover. We see the confluent erythema with a white ring spot, with somebody say it's white island in Red Sea. If you see this, it means the patient recover already. So in that case, we diagnose by dengue by clinical, which is a miss. But this case came with fever, vomiting, mild cough, and thrombocytopenia. This one, the test for dengue, IgM and IgG rapid test positive. So the diagnosis was dengue, and the nurse who took blood from this patient didn't wear mask and didn't wear PPE for protection. So after that, the patient developed shortness of breath, and chest X-ray show infiltration, and RT-PCR positive for SARS-CoV-2. And this was the first case of Thai healthcare who got COVID from this index case. This case, they haven't done RT-PCR for dengue, only the rapid test positive. Do you think this case is a co-infection of dengue and COVID or not? So you have to see this data. Sorry. This is the data of cross-reaction between COVID and dengue. First report in Singapore, 2 cases. You see the fever, thrombocytopenia, the feature of dengue, and then IgM, IgG positive. But RT-PCR for dengue in the urine and blood negative, SARS-CoV positive. So this case is a COVID case, but IgM and IgG cross between dengue and COVID. The second case, you see the clinical features look like dengue. You see fever, myalgia, cough, diarrhea, thrombocytopenia, IgM rapid test positive. Also have abnormal liver function test and lymphopenia. Later developed dyspnea, and they did SARS-CoV-2 RT-PCR positive, but dengue RT-PCR negative. So these 2 cases are not dengue, but there are cross the antibody IgM and IgG between dengue and COVID. So the diagnosis, if you want to distinguish between dengue and COVID, you have to do PCR test for SARS-CoV-2 or PCR test for dengue or NS1 antigen test. That is the only way that you can differentiate, not IgG or IgM or ELISA or rapid test. Case 2, this is a 50-year-old Thai female flight attendant living in Bangkok. She had fever, myalgia, nausea, vomiting for 1 day, 7 days before she traveled to Denmark. Her vital sign was normal, were normal except for fever. She had fever. The laboratory showed leukopenia, lymphopenia, elevated liver function test, liver enzyme, and hyponatremia, hypokalemia. Chest X-ray, no infiltration. So she was admitted to the COVID because that time we are so aware of COVID. Her dengue combo mean NS1 and IgM, IgG, faint positive band of NS1 and IgG. RT-PCR for dengue positive for dengue 2, RT-PCR for SARS-CoV positive for SARS-CoV-2. So this case are definitely co-infection. And let's see whether this co-infection going to be severe or not. Fever resolved after hospitalization and laboratory came to normal within second week. So this was the non-severe case. And you see the dynamic or laboratory, the hemoglobin doesn't increase, no hemo concentration. Only only low normal platelet, not thrombocytopenia, and liver function test abnormal. So these are my case. So can COVID and dengue co-infection lead to the severe infection? Majority of the report are case report from many countries, from Argentina, Brazil, United Island, Mayotte Island. This is French department in Indian Island, in Madagascar, India, Indonesia, and Pakistan. Majority, the co-infection are not severe. But there was one fatal case in Brazil. A lady, 60 years old, has underlying disease of obesity and hypertension, which obesity and hypertension are the risk factor for severe COVID and also are the risk factor for severe dengue as well. In another severe case is from Indonesia, 10 months old child have severe dengue shock syndrome with this DIC, this disseminated intravascular coagulation. Only one case study from Pakistan. They took 20 ICU cases who were diagnosed as COVID by PCR, and 5 of them were also positive for PCR for dengue. So these are the 5 are the case of co-infection, and 3 out of these co-infection die. So dengue and COVID co-infection may cause severe disease. Sorry. So whether it's ADE, activity-dependent enhancement in dengue and COVID cause the severe disease, there were studies that sera from SARS or MERS vaccinated animal enhanced SARS-CoV-2 infection in vitro. But this study was done in the cell culture that cell had Fc gamma receptor. Fc gamma receptor is a receptor on the macrophage, monocyte or Langerhans cell, which enhance cause ADE in dengue. But in SARS-CoV-2, the receptor is ACE2, which on the surface of the cell of bronchus or pneumocyte of the lung, and some parenchymal cell, not FC gamma R. So this is the study done is not in the receptor cell of the COVID. And the ADE does not contribute to severity in normal human coronary infections. You can notice that the person who have once have COVID infection and then had the second one, it doesn't cause more severe disease in the second infection. And the same for those COVID vaccine, when the immunity wane in 3 to 6 months, the new infection, even from the different variants, cause not severe disease. Actually, it caused less hospitalization and less severe disease for those immunized people of COVID. So no strong evidence to support that ADE between SARS-CoV and dengue. So our practice is still the same to avoid dengue is to avoid mosquito bite, because it is the vector for the dengue. So this measure, you can look at the yellow book. Okay. And in Thailand, for COVID, we practice the Thailand new normal plus vaccination. This is Thailand new normal: distancing, mask wearing, hand washing, temperature check, testing for COVID. If there is symptom, then application in the mobile phone. This is the picture of the first flight to Phuket Sandbox. You can see that now travelers are in the small group, in close friends or their families. And this is Phuket Airport, International Airport. So we learn to live with COVID. We have Phuket Sandbox start in July, and then Samui Plus in the 1st of August. And then we have Phuket Sandbox 7+7, another route, stay in Phuket for 7 days and stay for another route for 7 days in Phang Nga, Krabi, or Samui. So everybody who come to Phuket have to have 2 vaccination against COVID. So this is my last slide, my conclusion. There are cross-reactivity between dengue and SARS-CoV-2, which can lead to the false positive dengue serology among COVID-19 patients and vice versa. So the recommendation for the diagnosis to confirm is PCR NH1, not antibody IgG or IgM. No strong evidence to support ADE between SARS-CoV-2 and dengue virus. Co-infection may cause severe illness. And Thailand, we live with dengue for more than 20 years. We also live with influenza. Now we learn to live with COVID-19. Thank you very much.
Thank you so much to all 3 of the speakers. Pontep, if I can ask you just to stop sharing. Wonderful. Thank you to all our speakers for those excellent presentations. Please, I encourage everyone to put any questions that you have into the chat. Thank you. And I think I saw one question already from, there have been huge problems with notification of disease in general during COVID. And this is perhaps a question for you, Annalise. Many countries have seen a decrease in reported cancer, heart attack, stroke, etc. Is there any data to validate the decrease in dengue, perhaps with serosurveys?
So indeed, underreporting because of now suboptimal surveillance, and all the issues of distracted personnel is a confounding factor, and for all diseases. That said, though, after the initial months, most of the surveillance got back to scratch. So for example, influenza, yes, it dropped, but really is back to normal. And the decline that we see in influenza, I think, is a real decline. And now for dengue, I do agree there are many confounding factors. What we used to validate was the death rate, the case fatality rate. So if you have, so deaths, get reported, right? I mean, if you die, you get reported. You're in hospital, you get reported. So we decided if the case fatality would rise because the denominator is lower, then we have a problem. But indeed, we did not see that in the study that we did. But we acknowledge the confounding. It is definitely a problem.
And Aloysia, did you have anything to add to that? Because I think that study that you mentioned from CID is really interesting. And you mentioned what the seroconversion was in, I think that was from 2019. It'd be really interesting if there would be follow-up data, although obviously there's going to be problems with cross-reactivity if we rely on dengue seroconversions based on what Pornthep showed with the potential for IgMs and IgGs to rise from dengue in the setting of COVID.
I agree, Karen. This is a very interesting setting for those studies to be conducted in, since we have been following these population cohorts for quite a long time now. We have local teams who really frequently visit those households, and there are, let's say, scheduled collections of blood to occur every now and then in the study protocol. According to sero cross-reactivity, in that particular group of patients, we didn't see cross-reactivity. So none of those seroconversions to dengue led to seroreactivity in the COVID-19 ELISAs. And apart from that, we will have the chance of following this population with future collections. And this will make a better sense to adding to what Annelise has said. Apart from detection from surveillance, we can see what is happening in terms of seroconversions to dengue in those in that area. One problem with the serological testing for dengue, of course, is the fact that we all know antibody titers tend to decline after a certain period of time. So if we don't have a close monitoring of symptomatic disease, we may have the chance of finding people who don't exhibit anti-SARS-CoV-2 antibodies in a particular collection, but who in fact have been infected with COVID-19. But as far as dengue is concerned, I think this is a perfect setting to conduct those prospective studies.
May I ask you one question? Also the same that Karin said. You have Zika in your country,
yes.
And this also cross reactivity against dengue.
Yes.
Can
in fact, that is
be
true.
Zika as well?
Yeah, that is true, Pornthep. But we are not much concerned about Zika because of the behavior of the Zika pandemic that has waned significantly, and we don't see many settings of residual Zika transmission anymore. But we should be concerned of another important confounder, which is vaccination against yellow fever. Of course, vaccination against yellow fever is universal in the Amazon region. And so this is a potential confounding factor as well for sero cross-reactivity.
I have a number of questions. One when we talk, you all mentioned, you know, the multiple reasons for potential underdiagnosis. Do any of you have any data on the number of dengue tests that were done in your labs? Aloisio, you mentioned that the labs were overwhelmed with, you know, doing COVID testing. It might give us some idea about the proportion of dengue tests that were positive if we knew something about, you know, the denominator, and might help us understand how much was due to not presenting or not getting the test done versus, you know, a real decline.
This is something, Karen, if I may add a comment, that we might be able to study retrospectively, because samples have been collected, they have been sent to public health reference laboratories, but of course, the testing itself has not been carried out due to the overload of those laboratories which were involved in the rapid response to COVID-19. But we have significant and important sera collections that could be used to answer your question.
Pornthep, would you have a mechanism for looking at the number of dengue tests done in the last 2 years, in 2020 and 2021 compared to previously?
In Thailand, the case report that I show you mainly is clinical diagnosis. Very few that they did ELISA and do for rising or PCR for dengue serotype. But in general in Thailand, it's clinical diagnosis. So we have no data.
Okay, I'm going to encourage the audience to put any other questions in your question box. Otherwise, I'm going to keep on going with my questions. And perhaps this is a question for all of you to answer, but we were talking about the public health measures and the public health messaging that we now have for COVID, and that obviously includes, you know, washing your hands. How do we think that any of the messaging about COVID it might have led to more or changes in water storage around the house, and perhaps been a risk for COVID, and perhaps not in the past, but moving forward, how are we going to combine the public health messages to ensure that we don't, you know, by trying, you know, just to decrease one, that we're not exacerbating the other?
So if I may start, I think this is a good opportunity to become very creative. I mean, there are totally different outbreaks and totally different pathogens and different age groups. So, you know, they really differ, but both, you know, happen at household level, and transmission is high at household level, especially for COVID. And I think using those two diseases, but probably more, you know, it's more than dengue. I think, you know, the public is hungry for messaging and for education, and really to use this, and it must be then context specific, and it will be different from country to country. And I think and as you said, there will be a lot of data coming out in hindsight, so retrospective data that will show, you know, the impact of hand washing on diarrheal diseases, or on distancing on sexually transmitted diseases. So there will be a lot of very, very interesting studies coming out, and I think a lot of lessons to be learned far beyond the COVID response. And, you know, and influenza, I mean, I find it so fascinating that influenza was so suppressed just because of all these measures that we took. And of course, we never want to repeat those measures again for influenza, but I think maybe we can pick out and learn which can be used for influenza. Over to the others.
I would like to add a comment to that point, and that is the importance of paying attention to other confounding factors, because we are now experiencing a very important drought in Brazil, in many urban areas of northeastern and southeastern Brazil. So this, we have experience from previous situations in which we suffered from this, that this is exactly the environment when people tend to accumulate water in an appropriate ways in the household. So despite having had all these public health measures, if you are compelled to accumulate and store water because you are concerned that you might have this water shortage at your household, this will overcome whatever positive message has been learned during the pandemic. So it's a very complicated situation because, of course, people are pressured by their immediate needs, and sometimes the immediate need is to have water at home somehow.
Pontep, did you have any local experience from Thailand?
I think the main for COVID transmission is through respiratory tract. So other is just contaminate, which I think fewer virus, the main one. So for me, I think that social distancing is very important. And then wearing masks to reduce the number of the virus. Other measure is just to help, like washing hands. But the most important is the social distancing.
So in the chat, there's the comments about the co-infections and as Annalise has responded, that everyone being hospitalised for whatever reason, we should be thinking about COVID, because we know now, particularly as vaccination increases, that many people will be hospitalised with COVID, not because of COVID, which makes me wonder what multiplex blood testing we might be seeing in the future with antigen and PCR tests we've tended to group them in respiratory infections or vector-borne diseases, but we're really needing to think broadly about the multiple co-infections that people can have and the multiple exposures that people can have. And I wonder if there's any news of any multiplex kits that people know about? No.
Also, very good creative thinking for the future, for the immediate future.
And another question in the Q&A, has anyone ever clearly demonstrated that dengue outbreaks can be linked to large congregate settings?
So I'm happy to take this because of the nature that there's already a lot of herd immunity, and therefore most adults are some way already protected. And this is a pediatric disease in most endemic countries, or an adolescent disease. We really have, I don't know of any report of a real outbreak because of a mass gathering. This is not how dengue behaves. It doesn't mean that you can have clusters and smaller outbreaks, but really a massive explosive outbreak as a result of mass gathering is unlikely.
Yeah, thanks. Anything else to add? I'm interested in another question. I've got another question on Pontep. One of Pontep's slides, I think you said that there was unlikely that COVID-19 vaccinations would sensitize people to ADE, but I guess there's things we don't know about enhancement of the immune system. And do we suspect that in the future, if and when we have regular COVID boosters, perhaps annual COVID boosters, that we might want to time it away from the dengue season for that reason?
If you look at the one that I said, that there was a study in animal vaccinated with MERS or SARS-CoV. And there was enhancement because they used FC receptor as the cell culture. But previously, many people afraid of Q vaccine because there was in the history that measles vaccine, Q measles vaccine, caused when immunized children and when children infect and got infection, breakthrough infection, it caused a typical measles. And this also occur in RSV, respiratory syncytial virus. So people are afraid at the beginning of Sinovac vaccine and Sinopharm. But if you look at the paper of Halstead, Scott Halstead, he mentioned that this is the phenomenon that he called vaccine hypersensitivity, not ADE. And the ADE should be more severe than a typical measles that previously occurred. So this is one of the evidence that COVID vaccine is unlikely to cause ADE. Okay.
I think it's very important to re-emphasize this message that Pornchap just gave. There's no evidence clinically that the vaccines, any of the vaccines can enhance or can cause ADE. And there was no clinical, but also most importantly, of course, first we had the animal studies before we went out to humans, and there was no ADE seen in animals. And they did various, so because ADE is thought to be, associated with lower antibody or declining antibody levels. So they did animal studies trying to simulate different antibody levels. And whatever they did in animal studies, we have not seen ADE as measured as increased pulmonary pathology.
That's really reassuring. Thank you. There's a comment, perhaps more than a question, from Santanu. It'll be interesting to see how wearing masks will impact TB in India. On the one hand, the TB control program has taken a backseat, while on the other side, wearing masks may have an impact. I think that's the really, as Annalise was saying, we've got so much that we're going to learn about so many other diseases from the interventions that we're all getting used to from COVID. I think that it's fascinating that flu seems to have gone down more than perhaps RSV and some other viral infections. So these differential impacts on various infectious diseases that I guess we'll monitor over the next couple of years are just going to be, I think, fascinating and tell us a lot about differences in host susceptibility, in viral confidence or and pathogen confidence in spread, in the nuances of spread, etc. I would imagine, and I wonder whether anyone's brave enough to predict if and when we're going to start seeing the resurgence of infections that perhaps have been diminished by all the factors that we talked about that might be impacting on dengue. Do we think that we're going, which diseases might we expect to see in the next 12 months versus which diseases are going to take longer for us to see a resurgence? Annalise, do you want to?
Yeah, I'll start with the concern that the global scientific community has on the resurgence of vaccine preventable diseases as part of the disruption of national pediatric immunization programs. And there's a lot of data. I mean, there's in some countries, all campaigns stopped, the polio campaign stopped. So there's a fear of polio resurgence. People really fear that measles will come back in the young children who did not receive the vaccine. There's a distrust now against systems, and now retargeting those children who did not receive it in their normal age window is going to be a programmatic challenge. So I predict all those diseases will increase in the very near future. As for influenza, I know that that WHO had just had a SAGE meeting last week. Was it last week? Yes, last week. And they and the concern was expressed that influenza could really come back this year. And there's now a major effort to ensure that we have now also higher influenza vaccine uptake for this year. I personally don't think so. I think it will be next year, but let's see, you know, never say anything too early.
I think so.
I would like to raise again the point of our concern about the increase in poverty worldwide. So this is very significant. And this is a matter that is going to affect large number of countries throughout the globe in many continents. And this will, of course, require an international effort to support those countries in maintaining the public health programs, not only immunization, as Annelise has said, but many other programs in order to prevent the diseases peak in the next few years. So this is something we should be, as members of international scientific societies, we should always be bringing this back to the attention of the international community.
It's really a time for learning of how to coordinate things in a way that doesn't just add on more expenses and more another programmatic response that's needed. But as Annelise, was saying, really learning from this to combine our efforts and to ensure that with as few resources as possible, we can cover as many diseases as possible. The question has just been posted, will the COVID vaccination programs themselves interfere with traditional vaccine programs?
Yes, Michael, this is exactly what happened. So all the mass campaigns, the SIAs for polio, for example, but also measles, were totally disrupted in 2020. And so the fear is justified that those vaccine preventable diseases could reemerge.
Well, I know we're almost at time. Perhaps I'll just ask if any of the panelists have any final comments that I didn't give them a chance to say. Otherwise, I'd like to take the opportunity to thank the ISTM and the organisers again for this for hosting this fabulous webinar, and in particular to thank Annelise, Aloisio and Pornthep for their fabulous presentations, and also for this great discussion that by keeping to your time limit of 20 minutes, we've actually had time to really bring out all these issues in the discussion, which I think has just been superb. So thank you very much. And back to you, Yen. You're on mute.
Thanks, Karen, for an excellent moderation, and thank you to our speakers. Another great session, and thanks to everybody for attending this session, and we'll see you again soon. Watch your emails for the next announcement. Take care now, and we'll catch you later.
Okay. Bye. Hi, Nelly.
I would like to thank again for the invitation. It was a pleasure to meet all the colleagues here and to take part in this discussion. Thank you for the opportunity.
Thank you
Okay,
so much,
I would like to say
Aloisio.
thank you as well. Yeah,
And Pornthep, really great. Thank you.
very glad to see you.
Bye, everybody.
Okay. Bye.
Sleep
Hope to
well,
see you in the
Karen.
future. Yeah, person. In the future meeting, hope to see you. Good night.